Hello, hello everyone. It's really nice to be here. It's a pleasure and an honor to be here moderating this session with my dear friend August. We'll be talking about point of care ultrasound for the young internists. This session will be divided in mainly 4 parts. So 3 small presentation first, and then the discussion, who we want to be really productive. So everyone who's attending, feel free to use the Q&A button below the screen to address every question you want. So the more the questions, the better, and richer the discussion. We'll be on it to do it, and then so we can start. So first of all, in the name of the Young Internist and EFIM, thank you, Professor. And I think we can go on with August with this webinar.
Dear Miguel, thank you very much. Dear colleagues, good afternoon from Madrid. My name is Oğuz Abdullah Yoroğlu, and I'm the Young Internist representative of Turkey, and I'm one of the subcommittee members of Young Internist group. To be honest, I'm very excited because it's a great honor for me to being dear Professor Juan today. And actually, I got the chance for working with him since January, since 4 months, my last 3 months as a trainee in his point of care ultrasound unit. I think it's a great honor for me, and I saw that he's working very efficiently in his point of care unit as a chair with his great team. And dear Professor, on behalf of the Young Internist group, I would like to say you again welcome and thank you for accepting our invitation. And actually, before the beginning, I would like to share with you and with the audience about our survey. And let me first give you some information to the audience about you.
First, we have to share the presentation.
Yes, I would like to share my screen.
Yeah.
Yes, dear colleagues, today we are together with Professor Juan Torres Macho. He is interested with POCUS since 2009, and he was one of the founders of the ultrasound working group in Spanish Society of Internal Medicine. And between 2014 to 18, he chaired this working group. He has lots of published articles about using point of care ultrasound in internal medicine, in patients with heart failure, COVID-19, and in some emergency settings and medical education. Now he is the head of internal medicine department at Hospital Universitario Infanta Leonor and Virgen de la Torre in Madrid in Spain. And he is the current chair of European Federation of Internal Medicine's ultrasound working group. We are really excited and happy to be with you here, dear Professor. And as I said before, I want to share our survey's results before the beginning with you, because at the end, when you saw the results, you will understand how point of care ultrasound is important for young internists, or you will get the chance, the young internist perspective about point of care ultrasound. Dear colleagues, as you know, we spread a survey named Challenge in Internal Medicine in 2023 between many European countries who we have associations with our national societies. Actually, the aim of this survey was to understand or to detect the difficulties or problems about internal medicine training, or when we are practicing in internal medicine in our countries. And we tried to put more options for detecting these aspects. This was one of the main questions, and we asked you, which of these aspects do you consider to be current challenge in your training and in your career in internal medicine? As you see, we have lots of options like heavy workload or some insufficiencies about research or some facilities, for example, clinical skills, soft skills, research activities. But we thought that we should also put an option here about ultrasound, because, dear Professor, you know, to perform ultrasound or to get an ultrasound machine or to get an education in point-of-care ultrasound is also a problem, also a challenge in internal medicine in all European countries. And the results were really supported our thoughts. As you see over here, more than 50% of internists stated that ultrasound skills are also a current challenge in our education or in our profession. And the second question was about performing ultrasound. We asked who performs ultrasound in your country. The results were as expected because the main physicians were radiologists. Yeah, that's the normal one in all around the world. But we saw that even if they have certificate or not, we don't know yet. But approximately 40% of internists stated that they have already performing ultrasound, but the rate for the only internist option, as you see on the top, were really low as 4.2%. And I think this was the second main question about ultrasound in this survey, because we tried, if you are certified to perform ultrasound without taking supplementary classes or courses from any other organizations or any other universities at the end of your residency. Actually, with this question, we tried to understand that if you have the chance or option during your residency, or if you have the point-of-care ultrasound training in your national internal medicine curriculums, because this is an important point. But unfortunately, we saw that 65% of internists don't have this chance. So this is a big point that we should, I think, discuss today about point-of-care ultrasound. But we have some good news from some countries. We saw that especially in Italy and in Spain and in Romania and in Austria, they have the chance for certificating both point-of-care ultrasound and abdominal ultrasound at the end of their residency. I think that's also a big chance for them. And the last one, we asked about the importance of ultrasound, and the results were, again, as expected. Many of, maybe the overall of internists stated that POCUS is extremely important for internists. And dear professor, as you see here, young internists want to learn POCUS. Because of that, we invited you today to learn or to hear more about point-of-care ultrasound. Thank you very much. And we are really, really excited to listen your presentation. The microphone is yours, please.
Thank you. Let's see.
We wanted it to have a studio ambience, and with the same camera with Professor Juan, and it's really exciting.
No, it is to prove that you are here with us.
Yes.
Okay. I don't know if I am sharing. Yes. So I will try. Good afternoon to everyone, first of all, and thank you very much for the invitation. It's a great pleasure to be here with the Young Internist and to try to show a small framework about point-of-care ultrasound and which are the projects in the EFIM ultrasound working group. I will try to be brief, because I think the most important thing in this webinar is the discussion and to have a good debate. So I will try to be short in my presentation. But first of all, I have to explain what is point-of-care ultrasound, because point-of-care ultrasound, or POCUS, is not the same as a comprehensive examination performed by a radiologist or a cardiologist. It is the use of ultrasound in our patients, which will be performed usually at the bedside of the patient. And it will be performed by the attending physician of the patient, who really knows what is happening and which is the differential diagnosis. And that's one of the most important things and advantages of a point-of-care ultrasound, that you know what you're suspecting, and what you're doing is to confirm that suspect after a good clinical history and a good physical examination. It has to be complementary and performed after the diagnostic process. And the other point is that it is used in specific clinical settings. We know where it is useful and efficient to do, and the learning curve is relatively short for that scenarios, for that clinical settings. And that's the one of the strengths of point-of-care ultrasound. So we have to be sure that it is different from the comprehensive examination. That is why there is no conflict with radiologists, cardiologists, etc. In fact, in the latest year, it has been defined as the fifth pillar of the bedside physical examination. It's been called insonation. So as you can see, it is not the same as the classical ultrasound examination. And when and where are we going to use point-of-care ultrasound? In different moments of when we are seeing patients. First of all, we will make the anamnesis and physical examination. Then we will use in that moment POCUS to confirm suspects, like we think that there is splenomegaly or not, a pleural effusion or not, a good ventricular function or not, etc. We used to make dichotomic questions. Then we perform diagnostic tests, and we make an interpretation of the data. And when we are making the diagnosis and treatment plan, we can also use POCUS to establish prognosis. And after starting treatment, we can check the evolution of the patient. As an example, when we evaluate the degree of lung congestion in patients with heart failure, we are checking it with lung ultrasound, and we can see how the treatment is working. And which organs are we going to check? Different sites, like abdominal ultrasound. We will see the abdominal aorta, the biliary tract, and the gallbladder, the kidneys, to see if there is hydronephrosis. We will also perform a cardiac ultrasound, checking the top 5, left ventricular function, cardiac dimensions, the presence of significant pleural effusion, the presence of a significant valvular disease. And we also can perform optionally vascular ultrasound. That is called the multi-organ ultrasound examination that can be performed only by generalists. It is rare to see a cardiologist performing an abdominal ultrasound or a radiologist performing a cardiac ultrasound. So we got the power with generalists like internists, emergency physicians, intensivists, anesthetists. We can check the whole body to enhance our physical examination power. Some years ago, before the COVID-19, the working group published a basic position paper about point-of-care ultrasound, which are the aspects that we can check and which is the learning curve. It is basic, but it's common for all Europe. That's what we tried to do. When you read that paper, you could think that it is simple, but it's the starting point for all the European countries that begin to EFIM, and I think that it's a very important document that will be the beginning of everything. The other important point in the latest year is that devices are much smaller than previous, and we can carry it in our pockets, and we can use it every time we need it. Because if you're seeing a patient and you need an ultrasound examination, if you have to go for the machine to plug in, to charge it, and then use it, you won't do all the ultrasound examinations that you need. So the best way is to wear it on the pocket, And there are, as you can see in the slide, different devices. And this is one of the changes that have enhanced the use of pontifical ultrasound the latest year. And how can we measure the power of pontifical ultrasound? I'm going to show you 4 or 5 slides about this. First of all, about how it enhances physical examination capabilities in physicians. We have these publications from Mayo Clinic Proceedings from 2016, where we can see which is the sensitivity and specificity of the classical physical examination in different clinical settings, and which is the diagnostic accuracy of pontifical ultrasound. And for example, to detect pulmonary edema or pneumonia, we can see that the classical physical examination sensitivity is among 20% to 60% in crackles, and 4 to 50% for pneumonia and auscultation. And using pontifical ultrasound, we have more than 90% of sensitivity and specificity. Another example is to detect left ventricular dysfunction. We have the third heart sound, which is very specific, but the sensitivity is very low. And when we use pontifical ultrasound, we are close to 90% of sensitivity and specificity. When you go to the abdomen, it's similar. To detect splenomegaly, we have a 25% of sensitivity and from 30 to 90 specificity, and pontifical ultrasound, we are close to 100%. And to detect free fluid in the abdomen is similar. We have low specificity, and when we use pontifical ultrasound, the diagnostic accuracy is very, very high. So we have some proofs about the how pontifical ultrasound enhances physical examination. And we also have different clinical situations. I brought 3 or 4 as an example. The first one is during CPR, when we have a shock or the patient has a cardiorespiratory arrest. Pontifical ultrasound is very useful. We can detect, as we can see in the slide, we can make a heart ultrasound examination, and we can see, as we can see in this slide, a heart with a cardiac tamponade, with a broken heart, with a lot of blood, hemopericardium. Or we can check and we can see an abdominal aortic aneurysm, which can explain the situation of the patient, and we can make an etiological diagnosis immediately. Another example is the evaluation of cardiomegaly, and as in this example, we can see a patient with cardiomegaly with B lines. We can think that it's a heart failure, left heart failure, and we can start on diuretics. But when we check the heart, we can confirm that that cardiomegaly is not because of big chambers. It's because there is a significant pericardial effusion. So we can change the treatment and avoid complications due to inadequate diuretic treatment. Another example is a small bowel obstruction. You know that plain X-ray sensitivity and specificity is relatively low, and if we apply ultrasounds, we can check signs like the dilatation of the small bowel, the presence of edema, and the towards and frowards sign, or the Tanga sign. You detect edema, and you increase your diagnostic accuracy. And finally, in patients with heart failure, a new situation has been defined. It's subclinical congestion. Is when the patient doesn't have dyspnea, there are no crackles, but when you perform lung ultrasound, you find what is called B lines, which is directly related to the content, the water, extravascular lung water. So we have pulmonary edema, even though there are no signs or symptoms. And this happens in more or less 30% of patients who are discharged from an episode of acute heart failure. And we already know that this situation is closely related with mortality and the risk of rehospitalization. So we have better information than previously to see which patients we have to make a close follow-up, or we can discharge the patient and see him or her after a month or later. So after those examples, that there are much more, but I didn't want to extend more in this aspect, which is the learning curve. As I said previously, the learning curve is relatively low. To obtain a basic training, it's more or less defined as 1 month in an ultrasound unit or an internal medicine unit, performing ultrasound every day, multi-organ ultrasound. That is for basic ultrasound capabilities, okay? If you want to be more confident, maybe you need a longer stay, like August is doing now. It's more or less, he will stay 4 months, but that would be to become a relatively expert and a trainer, okay? But with 1 month, is enough to begin performing ultrasound. If you have in your center a mentor and you have an ultrasound machine, you can begin performing it. It is established more or less that in abdominal ultrasound with 20 to 30 supervised examination is enough. And in cardiac ultrasound, you need a little bit more, between 50 and 150 examinations. Always, cardiac ultrasound is the most difficult aspect of point-of-care ultrasound, and you need a longer training period. And there are another uses of point-of-care ultrasound, like this you can see in the slide, the minimally invasive autopsy that we're performing in different European centers, or point-of-care ultrasound for medical training and medical education. It's very useful, and to also to make research in different aspects. And which are the limitations? August previously talked about them, but the most frequent one is that the ultrasound machine availability. And after that, the most frequent excuse is people say that they have no time to train. But really, that's an excuse, because you have a lot of time, and above all, when you're on duty and night shifts, sometimes you have free time to perform point-of-care ultrasound if you have a mentor or you have the machine, or maybe just have the machine and ask for a comprehensive examination. You can perform a previous ultrasound examination explaining to the patient what is happening, that you're in training, and you have to check it before the radiologist. And then you have the gold standard, which is the radiologist. There are, unfortunately, still there are some institutional barriers in different countries and centers, because some places don't accept that internists can perform point-of-care ultrasound. But fortunately, that's every day, more countries and more centers are performing POCUS, and we need a training program, a common training program, trainers and centers. And what are we doing from the ultrasound working group? Recently, we performed a European survey that was answered by more than 300 people, and it was presented by João Neves, who is leading the project in the last EFIM Congress. That survey was performed for different reasons. The first one is to see what's happening in Europe, similar to what you've done in your working group. But we also want to establish a network. And now we're making a second round of the survey to know which centers in Europe are prepared or ready to accept people to be trained there. Above all, residents, first one. And second, to establish a research network also. So probably in the following months, we will be able to establish at least a map or set of centers where residents would be able to go to be trained. Okay, we also will try to establish a training program, a basic training, common and basic training program, and a certification. Those are the plans, and I think it will be very important to enhance research and training. And to conclude my presentation, I can confirm that point-of-care ultrasound is an extraordinarily useful tool for internists. It can make us better physicians. It should be included in all internal medicine residency programs and in the European curriculum. And we are trying to establish a European network to try to improve research and training along our continent. Thank you very much.
Dear Professor, thank you very much for this great presentation. I'm always trying to understand what the point of care ultrasound is from my side, but your presentation answered my many questions. And Miguel, I know that you have also experiences in point of care ultrasound, and at least 5 years during your residency. I know that you also believe point of care ultrasound in internal medicine, and you have, and actually we also want to share your experiences. I know you have a working group, you are leading a working group in your country, and you are organizing some training courses actually in your country. So I would like to give the word to you to share your experiences with us, with the internists in all Europe.
Yeah, thank you so much, August. I'll now do my quick presentation. I hope everyone is seeing my presentation.
Yeah. Okay, now we see it.
We will talk about it. It's the ultrasound for the Portuguese experience. It's something like that I will talk about. So our working group is NECO, so it's the ultrasound working group within our Portuguese society. I was one of the co-founders in 2019, so it's a newborn still. It's one of the 25 working groups that we have in Portugal. And our main objective is, of course, education, so delivering some formation, some courses, also scientific production and divulgation, and diagnosis, study and treatment, so something like an advocacy here within our country, within our society. So these are the two main events that we organized. Last year, the first national meeting of our working group, and actually the second one will be happening this week. So later this week, I'll be going to Lisbon to our second meeting. And as you can see, each meeting has an ultrasound, a POCUS course associated, so we can now give formation to our participants before the meeting. And so here in Portugal, the POCUS is a lot of wanted, and our courses are almost every time sold out. Just the program, it's in Portuguese, I'm sorry, but also I want to point it out here, just 2 things, because we have divided our session into parts. So the clinical ones, where we'll talk about intensive care ultrasound, heart ultrasound within the internal medicine, and then quiz. And for the afternoon, we'll talk about something more non-clinical, like internships, like I've done, some service, the ultrasound competency, if we want that or not, in internal medicine. So this is our meeting. Regarding our working group, this one was one of our first productions. It was published in our magazine. Here was our recommendations for ultrasound in COVID that we also write and divulgated in Portugal. And the latest here published this year about point of care ultrasound in internal medicine in Portugal, about our national survey that I will talk just a little bit right now. Because we have a survey within Young Internist of challenges. Professor also presented the survey for European for the EFIM, And in 2019, we also had one survey here in Portugal. It was a national survey online. It was anonymous. We had 283 participants, and although it may seem a low response rate because it was only 12% within all the internists, we got covered 52 hospital centers, which means that every hospital center that has internal medicine residency responded to the survey, which was really good news for us. It was divided in a few parts. So we have the characterization of population, the ultrasound use, formation and education, scientific investigation, the ultrasound internship and fellowships, and education capacities. And I just want to point out some of the results. This is one of our main questions, where we ask if it was important to include ultrasound in the internal medicine curricula. And as you can see, more than 85, almost more than 90% of the participants asked answered above 8, being a high level of importance to include ultrasound. And then something that quite surprises us is because, as you can see here, regarding ultrasound in the emergency department, we found that the equipment and the access was available, and also some tutor was available. So here in Portugal, as you can see here in ultrasound and here in the internal medicine ward, although within lower levels of availability of ultrasound equipment and access, what we found is that probably the equipment is there, but we don't have the expertise or the experts enough to do ultrasound. So just to sum it up, I was here trying to point out the importance of the existence of a national ultrasound working group that could and should be working within the European level to promote point of care ultrasound. The Portuguese diagnosis that I've been talking about, so we felt that the equipment was available, but we're missing some education opportunities. It is also important to have the ultrasound internship here in Portugal within internal medicine. And finally, probably we are doing the first steps into making POCUS the rule and not the exception in internal medicine daily practices. So this was my small presentation about Portugal, something that could conclude and come in the way that Professor was talking within Europe. And I hope everyone enjoyed and can have some questions later. So, August, I feel that you also want to share with us some experience.
Actually, I'm not sure if I attract the attention after your great presentations with Professor and you, but I have only a little bit experience in point of care ultrasound. Sure, it will be very short because I have only experiences in 3 months experience in point of care ultrasound, but I said a young internist POCUS story. Let me tell you about my short POCUS story. And yes, first, I would like to start with a novelist, with a great writer from Russian literature. This is Mikhail Bulgakov. He's also a doctor, and he is one of my favorite novelists with Dostoevsky and Tolstoy in Russian literature. And he has a book named A Young Doctor's Notebook, and he describes his experiences in his early years as a general doctor in the rural area of Russia. And you will ask me, where is your study? I put myself here as a candidate of a new writer in point of care ultrasound, and these are my documents, only a probe and notebook. And I would like to say you also that's my book, but don't worry, I've just started to write it about point of care ultrasound. Okay, this is my hospital, University Hospital, Hacettepe University Faculty of Medicine in Ankara, in the capital city of Turkey. And I'm working there as an assistant professor in the general internal medicine department. And I'm one of the consultant of internal medicine wards and also an acute care unit. Yes, we have an acute care unit. As you see over there, we call it Unit 75 with the capacity of 14 beds. But believe me, dear colleagues, we are doing really great things for our patients in this acute care unit. And as you guess, we have patients, most of them elderly patients with multiple chronic diseases, such as decompensated heart failure, chronic or acute kidney disease, asthma, COPD exacerbations. Sometimes we admit with patients with sepsis due to pneumonia, genitourinary infections, soft tissue, multiple organ failure, so on and so forth. I think you understood what I mean, the type of acute care units patients. But in this acute care unit, unfortunately, we don't have an ultrasound machine. Or even if we have, the consultants don't know how to use point of care ultrasound. I think this was my first problem. I always felt the need of an ultrasound machine in my acute care unit. And you will ask me for what? For detecting volume status, basically to assist my examination, or to diagnose or follow up patients with heart failure, or pulmonary edema, or pleural effusion, or sometimes to detect endocarditis or deep vein thrombosis. Or as you guess, we always need some catheterizations, both central or peripheral, or sometimes we need thoracentesis, paracentesis. And in these all situations, we always call the radiologist, and we are trying to convince them to perform an ultrasound, and usually they don't care, and they give the appointment for 2 days later, and then sometimes we have to do some maybe unnecessary complex imaging, like an computerized tomography. And I saw that, or I decided that to save my time, or to save my patient's time, or to save the need for more complex imaging, or to prevent delaying in diagnosis and treatment of my patients, to prevent long length of stays, or to decrease the overall cost, I said it's the fifth pillar of my physical examination, or as the guidance in decision making, and I call it as the game changer. I said to myself, all I need is a point of care ultrasound machine. And with these feelings, I've tried to find solutions for my acute care unit, but unfortunately, we don't have any courses or training programs in our curriculum, or also organized by internists. Yes, we have some courses, training programs, but most of them are organized by emergency medical associations. They are all emergency ER doctors. But I decided to join one of them. This was a one-day basic ultrasound course. Actually, this was my first step in point of care ultrasound. And between all these participants, I was the only one internist. All of them were emergency medicine doctors. And then I was lucky because the 17th WIN Focus World Congress was in Turkey, in Antalya, with the help of, again, Emergency Medicine Association. And I also joined that. That was my second step in point of care ultrasound. By the way, I think WIN Focus is a really well-organized scientific network. And if you are interested in point of care ultrasound, you should also follow their organization or their some activities. But yes, I took two one-day courses, but I didn't feel myself enough. And for my country, actually, I decided to talk with my society, the Turkish Society of Internal Medicine. And I made a presentation to them, to the governing board, about the point of care ultrasound in internal medicine and about the internal medicine's future with point of care ultrasound. And I convinced them to make a workshop in Turkey for internists. And you know what happened? They give the task to me, to organizing a task to me, and I was really happy because that was I needed. But the next step was to find the right person for this course as a lecturer or as a teacher to teach us POCUS, but in the vision of internal medicine, because I really believe that if we will learn point of care ultrasound, we should learn it from an internist with the vision of internal medicine, and the right person exactly was dear Professor Juan Torres, and I invited him to Turkey, to Antalya, in our national congress, and I really thank you again him to accept our invitation, and he came to Turkey, and we did a really amazing ultrasound workshop with the helps of, again, Emergency Medicine Association. I have to say that, because we don't have any lecturers or any lectures in Turkey as an internist. We don't have enough internists who performs POCUS. Most of them are also, they are performing, but they are intensivists. And we got really positive feedbacks. But this was not also enough for me, because I want to be a trainer, and I want to teach POCUS to my residents in my university or in my country. Then I send an acceptance letter to Professor Juan to accept me as a trainee in his point of care ultrasound unit, and he accepted me. I really thank you again here, and we are started really fast. This was my first patient. He was 34-year-old male from Senegal. He was diagnosed with sarcoidosis in 2017 with hypercalcemia and reticulonodular interstitial infiltrates. He was following with no treatment, and he was admitted to our emergency department with dyspnea. This was my first day and first patient. Then we went to the emergency department and we saw the patient, and we decided to perform a lung ultrasound. And they said to me, yes, perform ultrasound by yourself. Actually, I was shocked. This was a shock for me, because I don't have any, I had no experience point of care ultrasound yet. But then with the help of them, I did it, and I saw that sign. And now I know that this is an atelectatic lungs, and this is a jellyfish sign. And we detected pleural effusion. And then we discussed the patient at bedside, and we decided to perform a thoracentesis. You know what happened? They said to me again, yes, you should perform thoracentesis by yourself. That was the second shock for me. And yes, I know I have experience about thoracentesis. I did it several times, but I wasn't expected that in my first day, in my first patient, and we did it with the help of them. And now, in my first day, I really understood what POCUS means. You see the patient, you perform ultrasound, and you diagnose, and you decided what you want with the guidance of point of care ultrasound. And then we did several times. We detected left ventricular hypertrophy and hydronephrosis, deep vein thrombosis. We detected endocarditis. We performed VEXUS, so on and so forth. Actually, this story was not only about education. And if you are living in Iberian Peninsula, you have the chance to visit many places in Madrid, in Spain, and I also did it, and I really enjoyed with this education, but also a vacation for me maybe. And that was the milestone of my history, because at the end of 2 months, now I was one of the trainers in the POCUS workshop in Athens, in our European Congress of Internal Medicine. That was what I dreamed of, because, as I said you before, I was always wanting to know and to teach POCUS to my residents or to my colleagues. And my future plans about POCUS, when I come back to Turkey, and I will create a working group on behalf of my society with the help of young internists, because I know that there are lots of young internists in Turkey who are interested in point-of-care ultrasound. And we are gonna organize workshops for internists. And this is my future plan about my university, my center, to become a POCUS training center for internists. And I hope to admit the trainees in 2024. Thank you very much. I hope you enjoyed with my story. Please don't hesitate to contact with me for anything about point-of-care ultrasound and also internal medicine. I would like to say in Spanish, because I'm also learning Spanish in here. Gracias, muchas gracias.
So thank you. Excellent presentation, August. Excellent experience. It's really good to talk about it, and maybe to motivate people to learn and to search for point-of-care ultrasound, because as you said, and I agree, it's really a game changer. It does the difference, and it's really hard not to go for ultrasound now. So as we said, we want to have a productive discussion. I see that we have some questions, and maybe we could address them here. The first one, I can maybe I read it, and then we can discuss about it.
Yes,
probably.
please go on, Miguel, please.
So the first one from Bernardo Pimentel. So do you think there should be POCUS dedicated departments in the hospital? If so, how would you recommend to share this view to your colleagues, administrators, and stakeholders? A broad experience, or is there any literature about this?
Well, the optimum and the ideal situation is that all the members of an internal medicine department know basic point-of-care ultrasound. They wear their handheld device and they use it every day. But we think it more deeply, it is important to have some people who are more expert and to create a unit. Why? Because you need those experts, and it helps you to have people to train and also to make research. So if possible, a department should create a unit that is to liberate one or half a physician to perform the point-of-care ultrasound examinations that are needed in the department. But at the same time, you should try to train basic ultrasound to all the members of your department. That would be the optimal situation. Experiences in the States, they have units, but not units of half a physician. They have 2 physicians with the trainees and a lot of people, like in the Mass General Hospital at the emergency department is one of the most famous units. But I think if possible, in a department is good to have a unit for quality control, for training, and for research. But at the same time, as I said, we should try to train all the members. Okay.
At that moment, I would like to ask a question, Miguel, to the professor. In the case of that, we build an point-of-care ultrasound department in our hospital. Who will lead it? Radiologist or internist or ER doctors? What do you think about that?
The one who performed them. If a radiologist is able to perform a cardiac ultrasound, lung ultrasound, vascular ultrasound, abdominal ultrasound,
Okay.
should be the radiologist. If it's the cardiologist, the cardiologist. What really happens that only generalists, we have the open mind to perform a multi-organ examination. Okay? So it should be led by the one who can perform all of those examinations.
If I may, I totally agree with Professor. And here, one thing that and you both talk about it, that I really use to distinguish what we do is that we do physical examination and the radiology does diagnostic tools. So that's, I think, the main difference, because we don't have to, or we also shouldn't report something. We don't do reports. We do physical examination and we write what we see, and it's a lot of different, because and I agree that if there is a POCUS department, should be generalists in front of it, either internist or emergency. Well, the first one who has idea, because but the main focus is to be a generalist, because we have the holistic view of the patient, and then we can integrate POCUS in our clinical reasoning, something like that. Yeah, so I think that this between the physical examination versus diagnostic tool is one of the main arguments that we have to distinguish what we do.
Mm-hmm. Imagine if you have to ask a radiologist to perform a daily lung ultrasound to check the lung congestions of a patient with heart failure.
Yeah,
it's impossible. You know,
it's true.
I cannot imagine.
I have another thing about to convince the managers. You know, we have the sensation, unless we cannot demonstrate well, but I think that the length of stay of patients is shorter, because you perform an immediate, you give to the attending physician an immediate information that helps that physician to take decisions. Yes. And I think that this shortens the stay of the patient. Okay.
Yeah, and for convincing the management, as I said before, to decrease the cost, it's also cost effective for the hospitals. Yeah. And Miguel, you touched a really good point about reporting, and we have one questions about mistakes and reporting some medical legal status if mistakes happens. One attendance right only that one, but I understood his question. He was asking that if we made some mistakes about reporting, or do we have to report what we did?
I think that in the literature, it's been defined, it's well defined which aspects can be evaluated by POCUS. And there is evidence about that. If you center your report or what you write down on those aspects, it's okay, because there's evidence about you have the capability to do that. And anyway, when you make a physical examination, when you think that crackles means liquid and it's not liquid, what happens? Anything, you know? So we have to center it, like Miguel said, as a complementary examination after physical examination, not as a diagnostic technique with an independent report and a comprehensive study. So I think there is no problem with that if you do what you have to do in the moment you have to do, and you have enough training. It's true that certifications are scarce. For example, I am a supposed expert and I don't have any title, you know, but I have experience, and I think there is a lot of literature, and in a lot of countries it's been accepted. You can see in the New England Journal of Medicine 2 papers in different years about point-of-care ultrasound, and it is admitted that different specialists can use ultrasound if they use it in the proper way.
Yeah.
Actually, let me just ask one thing to Professor, because it's regarding the reports. One, well, it's a problem that we have here in Portugal. As I said, we have the equipment in our hospitals, and we are starting to have the education opportunities to everyone. But I feel that one of the main issues now are the things that we call phantom exams. So people do ultrasound, do POCUS, they do treatment regarding what they saw, but then if we're going to check the clinical, there's nothing about POCUS there. And I think that's the main issue now.
Yeah, it's better to write it down.
Yes.
The problem is the phantom, the ghost examination. And if possible, it should be added in the PACS, you know, but for example, in our center, it's not possible nowadays, but the optimum, and some papers recommend it should be in the PACS to check for quality and for be reviewed by the cardiologist or the radiologist. For example, in our center, we do well with cardiologists, and we record the images, as August can confirm, and we go to the basement, and we, as the cardiologist, they check the images and they say, okay, it could be an endocarditis, we're gonna perform the comprehensive examination or not. With our radiologist in Spain is different, okay? By the moment they don't accept to work with us, and but they allow it, you know?
Okay, yeah.
And maybe the solution is, I think, in my opinion, to use it as a complementary issue of physical examination.
Yes.
And I think we should use the fifth pillar term more times for in our maybe medical faculties for a part of physical examination. Yeah. By the way, we have lots of questions.
Yes.
I guess. Yes. Please go on, Miguel.
We have the next one is about, it's a huge question actually, because it's, could you please tell us more details about using POCUS in patient with shock? So in evaluation with a patient with shock, it's
there are a lot of in the literature. So I think the answer is to send to this person some references.
Yes.
There are different protocols, you know, about that uses cardiac, abdominal, detection of free liquid, cardiac function, and in a moment in a view, if you make a subcostal view, in a moment you check the heart and you check the inferior vena cava, and you can define what kind of shock you're treating.
That's the main thing in emergency room in shock patients, because POCUS is really a game changer here, because you can reason about what's happening with the patient just by looking into the patient with ultrasound. So maybe going on, that's another question. Should we advocate that doctors in other subspecialties of internal medicine like cardiology and endocrinology learn POCUS?
Of course, but they don't have, I said before, I think the sensation is that they don't have an open mind to learn to check different organs than they are specialized, because endocrinologists perform thyroid ultrasound, cardiologists are beginning a little bit to perform lung ultrasound, but it's very difficult for them to understand the body as one, you know, but that's the point for subspecialists or super specialists, you know, different approach to disease, okay? But it should be great. Now, for example, in Spain, nephrologists are starting to perform cardiac ultrasound, lung ultrasound, and they are going very fast or learning a lot, yeah.
And there is a good comment here from Canada. And regarding that Miguel said, it's Bernardo Pimentel, and he says, I'm an internal medicine resident doing right now a POCUS fellowship with emergency medicine in Canada, and they have a very nice cloud system which is automatically connected to the US machine. Wow, it's good, and all the images get recorded also with notes. Then you can access the cloud everywhere. I don't know if it's the only way, but here it seems working so far. Yeah, I really loved it.
Yeah, that's Canada.
Would you like to say anything about that?
Yes, I think in the future we all have that. Okay.
Yeah,
great.
Yeah, we hope. And one more question from Czech Republic, if I may, Miguel. I would like to raise it again. Yeah, the question is about availability of POCUS. Sometimes advertisements for a quite cheap ultrasound machines pop up on my social networks. Okay, I mean those that require just tablet or smartphone to use. Are those small pocket probes really sufficient for real use and interpretation in terms of point of care ultrasound? Yes, I think this is a good question. Professor Juan, please.
Okay, it's a very interesting
also,
question. Yes. First of all, there's a recent paper by Neelam Soni that evaluates the different handheld devices. I don't know, I think it was the Ultrasound Journal, or I don't remember well, but it's very recent, so you can read that to know which are the advantages of every device. Okay, there are some that are better for cardiac, other for abdominal. But the point is what I said before. If you wear it in your pocket, you will use it whenever you need it. If you have to wait to get a better ultrasound machine, you won't do all the examinations that you need. That's the first thing. And the second, and it's not a thought of mine, it's a thought of some experts, different experts. Point of care ultrasound should be easy and should be performed without measuring when you get the experience. Because when you start performing ultrasound, you love to measure, to use the Doppler.
Just like me now.
Sound,
Yes.
pulmonary pressure, systolic pulmonary pressure. But really, point of care ultrasound should be performed without measuring, okay? That's the game changer. When you start to measure, you start to be a radiologist or a cardiologist. So the real use is without a very complex machine. Of course, you have, if it's possible, it's good to have it first to store the images, to show, to make a presentation, to make research. But the ideal is everyone with a handheld device, and then a good machine to confirm some things that you cannot see as well with the handheld device. That's the optimal situation.
Nice. So if anyone wants to ask another question, I think we have still some time. I don't know, August, what you feel.
Yeah.
Yeah. We have one more.
Yes, we have one more question.
About, I will read it, August, if it's fine. So do
Yes, please. The
you
question
perform the Vexus ultrasound protocol at your center? What are your thoughts about Vexus? What should be the next steps?
Actually, we were talking about Vexus, and Juan said, I don't believe Vexus. And dear professor, I'm now asking you on front of everyone.
I think that Vexus should be performed under research protocols by the moment. Okay? And above all, in internal medicine, maybe in intensive care medicine, when you are applying fluids and you are evaluating and checking the patient very frequently, and maybe could be useful right now.
Yeah.
Research is needed. A lot of research is needed. It's a promising protocol. It's a complex protocol. Above all, the renal evaluation, the kidney evaluation is not easy. And maybe in the future will be something that gives us some light. But I think by the moment that line ultrasound is enough to evaluate the volemia, above all, the overvolemia, the excess of fluids in patients. Yeah. But that's my opinion. Okay?
Miguel, I want to ask you that question also.
Yes, because I have a research protocol now going in my hospital, but it's in intermediate and intensive care. It's regarding septic patients, and that's the question. Well, whether we could use Vexus protocol to diminish the overfluid patients, because we all know that in our emergency rooms, when we got a septic patient, we'll do fluids a lot, and our question is whether Vexus will help us that. But the main obstacle is the expertise needed. I do ultrasound for 6 years now. The other investigator also do ultrasound for a lot. But first, we can ask for help to do this, because it's really difficult. The renal arteries are really difficult to access, the renal veins, and so it's not, for now, it's not something that we could do without thinking about it, or as easy as it should be, because it's really difficult to do it, to get the curves. But I do feel that's something that will help us later, so it will compensate the work that we have to do to learn it and to apply it, but it will give us some kind of important conclusions. And one of the first ones that I've noticed we are now searching for the first results, is that even when we have the vena cava not superior to 2 centimeters, we can see changes about fluid excess, mainly on the kidney, because it's more sensitive. So probably for kidney injury or something like that, we will find some higher sensibility of this kind of ultrasound. And that's something that I think it will help us for the kidney injury and so on.
And maybe it could be our last question, because it sums to everything about this meeting. the question about that, dear professor. If you want to perform cardiac, vascular, and abdominal ultrasound, each of these certifications are 6 months, each theory and practice. And is there a chance to obtain an European certification in POCUS? Everyone wants to learn about that.
By the moment, not, but we are working on that issue, and I hope that in the future we can develop the European certification, probably basic and advanced. Okay, but first the basic, and first we have to certificate centers, so it will be step by step. First, centers certification, and then when we have good centers to be trained, to develop the European certification course.
Okay, Miguel, also maybe we should ask the second question.
Go ahead, August.
Yeah, as the chair of ultrasound working group, and do you advise any textbook about POCUS?
There are lots of my textbooks and videos. I prefer to learn short videos on the internet, different web pages. Maybe you can check 5-minute sono and a lot of them. Maybe we could make a list and send it to the.
Yeah, we can share it.
We can share it. And I think that short videos are better to learn than a textbook, because textbooks, the pictures are not in motion, and that's difficult. When you try to learn in a textbook, is difficult. But for example, the classic Vicky Noble textbook is the basic one, or Neil and Sonny from the States also are very good textbooks. But I prefer to learn online. There are a lot of resources, a lot of short videos, very well performed, and you learn very fast. And TikTok, we have in Spanish internist Yaletun, who try to teach in 15 seconds different techniques. It's fantastic. So I prefer the internet resources, in my point of view.
And there is also one suggestion about a project about POCUS for internists would be done by EFIM or national societies, like video learning projects. Okay, maybe we can answer this question as coming soon.
Yes.
About my presentation.
Yeah, it's related to another project, EFIM project, cooperation with countries and developing countries, okay? But a basic course will be on EFIM Academia in the following months. Yeah. We're performing that for the cooperation project, but we will use it for all the EFIM members to access to it. So you will have a basic course, but there are a lot. I think in the internet, basic courses, there are a lot, and resources, there are a lot, but you have to look for a mentor. That's very important, to have in each center one person with some kind of expertise that you can ask that person when you're starting point of care ultrasound, because it's harmless. I mean, you can perform that, but when you have a doubt, you need someone to ask. Sometimes you can ask online if you send the images in an anonymous way, but it's better to have someone in your center to be your mentor, of course.
Maybe the last question, Miguel. It's also an interesting question. What do you think?
Yeah. I think this is the final one, and then we can end it with the discussion. So, could POCUS have a chance to certify as a side branch education in the near future for internal medicine? What do you think, Professor?
I wouldn't separate it, because we would become radiologists, and we don't want to be radiologists because they are fantastic. They have their mission and we have ours. And I think that I wouldn't separate it. I would put ultrasound after physical examination, and I wouldn't make a subspecialty or something like that. Maybe a unit is okay, but no more than that.
Yeah. So go ahead, August.
Yeah, if I may, at the end of this meeting, a take-home message, if I want to give a message, it would be we should use POCUS as one part of physical examination, I think. And I think it will be it will help us to cross these barriers also. This is my opinion, the last opinion.
And it makes us better physicians, I'm sure of that. And it's good for our patients.
Yeah, and as I said, it's getting more difficult to go against point of care ultrasound. The evidence is there. One of my favorite evidence, because we don't talk about it very much, is that POCUS is actually getting us closer to patients. So for doing POCUS, we have more time with patients, so we are talking more with patients. So even that, POCUS is giving us more time to talk to patients. So it's really a good tool to every internist or emergency physician.
Okay.
So I think we can conclude, August.
Yes, Miguel. And maybe we can take the main sentences of Professor at the end of the meeting, please.
No, I think I've said what I had to say, but
Okay.
I think that a lot of people want to learn and need to learn, and we have to work to allow all the European young internists to be trained and to create that network. That's our mission, and we have to spread this fantastic tool that helps us and helps our patients.
Thank you so much, Professor. In my name, in the name of Young Internist, it's really a pleasure and an honor to be here with you. I'm a lover of POCUS and enthusiast, and it's fascinating hearing you and with excellent presentations. My dear friend August, thank you so much for your presentation, your experience, and I hope everyone enjoyed it. We are available if you want to send us any questions or any information. So thank you so much, and see you for the next webinar.
See you. Bye.
See you.